Dr. Rishikesh MAYEE to present optical control of myopia progression.
Good morning. So at the outset, I would like to thank Colonel Dr. Shrikant for giving me this opportunity. I've been discussing about the treatment part of controlling myopia. Dr. Jasprit has very extensively covered the pharmacological part. I will cover the optical control of myopia progression. There are no financial interest in because some products will be shown here. When it comes to optical control, we think in terms of glasses and contact lenses. A brief has already been shared by Dr. Kavita, so I'll be going into the detail about the optical treatment now. When it comes to glasses, it is the undercorrecting myopia, bifocal or progressive glasses, or the newer generation of glasses which we call multiple segment glasses, and contact lenses, which includes bifocal or progressive contact lenses which have not been found to be that effective for controlling myopia, and orthokeratology Dr. Shrikant will be covering later on. So my job is mainly to cover the glasses, the newer generation of glasses. Before going into the details, we'll share the different theories which have been proposed for myopia progression. One is that myopia is associated with poor accommodation response, which can produce a hyperopic lag. So if you are able to correct that, you will be able to control myopia progression. That is one theory which the modalities which work on this are the undercorrecting myopia or bifocal or progressive glasses. We are more concerned with the second theory, that is the peripheral hyperopic defocus. What is this? I will be sharing shortly. The newer modalities of glasses, the multiple segment glasses, work on this theory. The third is that in myopia there is a mechanical tension in the lens ciliary body complex. So as a result of which there is less of equatorial elongation and more of axial elongation. So if that is able to be controlled, which is being done by as per the theory by diluted atropine, that will work for control of myopia progression. The fourth theory, which is a recent part, is that there are certain receptors, the photoreceptors, which are not functioning optimally. So if we are able to generate more signals from the adjacent photoreceptors, they might help in myopia, control of myopia progression, which is the newer type of glasses, or dot glasses. We don't have them in India. But that is one theory. So when it comes to glasses versus contact lenses for myopia control, the glasses have an advantage that they have a larger surface area. So a part of the surface area can be used for refractive correction, and another part can be used, the paracentral area can be used for myopia control. When it comes to contact lenses, however, the major portion is used for the refractive correction and only a small portion for myopia control. Different glasses have been tried in the past. One is the bifocal glasses in the form of executive bifocals or D bifocals, or even progressive addition lenses, PALs. Different companies have come out with different designs of progressive addition lenses. These are not the one which we use for presbyopia. They have a slightly different design. I mean, a newer PL has been launched recently in this conference also. I'm not remembering the company, but overall, I mean, in the past, the PALs or even the bifocal glasses have not, I mean, their results are equivalent to single vision lenses. So that is why necessity is the mother of invention. So we came out with a new theory which is called the peripheral hyperopic defocus. Now what this is that the parallel rays of light, they normally focus on the retina. In myopia, they are focused in front of the retina. But what happens to the peripheral light rays? It is believed that in myopia, the peripheral light rays, they focus behind the retina, so thereby producing a hyperopic defocus. Now retina tends to seek the point of focus, so that is why there is an axial elongation. If we are able to convert this hyperopic defocus into a myopic defocus by placing some kind of plus lenses in the paracentral or peripheral part of the glasses, they will produce a myopic defocus, as a result of which the axial elongation will not take place. This is the theory on which most of these multiple segment glasses are based upon. So all these lenses have a common design. They have a central area for refractive correction and a paracentral area which consists of hyperopic lens segments, either hyperopic glasses or astigmatic lenses. So there are different designs by different companies. DIMS is one of the type of multiple segment glasses which are called defocus incorporated multiple segments. They are being marketed by Hoya company. MyoSmart is the name. No financial interest, obviously. So they have a central refractive zone and a paracentral honeycomb appearance of +3 diopter or 3.5 diopter defocus glasses for peripheral myopic defocus. So these glasses have been there since quite some time, and lot of research has been done, and it has been found to be effective in 62% of the lenses of the cases. One of the important studies was done in China. They have studied the children for 2 years, 3 years, and recently for 6 years. At the end of 2 years, they found that in terms of spherical equivalent change and in terms of axial elongation, both the DIMS overscores or the single vision lenses. So no doubt that DIMS does work. So they studied the same set of patients over 3 years, but what they did was after 2 years they converted all the single vision single vision lenses patient into DIMS. So they found that for those who were on DIMS for all the 3 years, they had good myopia control. More important is those who were on single vision lenses for the first 2 years, when they were converted into DIMS in the third year, the control of myopia is significantly more, as it is seen from the first the row, both in terms of spherical equivalent and in terms of axial elongation. This study, this same group, they studied their effect over 6 years later on. This was published in 2023 or 24, and in this, what they did was they divided patients into 4 groups. One is those who were on DIMS, those who were initially on single vision and then on DIMS, and after some time, some patients they dropped out, they opted for the single vision lenses, so they wanted to study the rebound phenomenon also. So the important conclusions from this study was that there was a sustained myopia control with the DIMS glasses over prolonged period of time, that is 6 years, and definitely it works better than single vision lenses. Those who were converted, the third and the fourth group, they converted back to the single vision lenses, but they did not have any rebound phenomenon. And also the other optical side effects like optical aberrations or spherical aberrations were not seen with DIMS over extended period of time. Coming to the second type of glasses is the HALT, that is called the highly aspheric lensless segment or lenslet target. These lenses are by Essilor, I think the name is Stilest. So these are also available in India. Again, they have a central optical zone and peripheral or paracentral aspheric lenslet zone. If you want to see, they appear like a single vision lenses, both DIMS and this. So if you put a camera flashlight over a white background, you will be able to see those concentric lenslet segments. The inner ring has around 28 and the outer ring has around 157 lenslets. They have, according to the studies, again one important single center trial, in 157 patients, they found they had 3 groups. One is the single vision lenses. They initially tried small aspheric astigmatic segments also, that is SAL, and then the high aspheric lenslet, and they found that HAL, the third group, they had the best outcome in terms of myopia control, both in terms of spherical equivalent and axial elongation. So they studied this group over 5 years. This is a recent study which has come out, and they found that over 5 years also, compared to the extrapolated single vision glasses, due to paucity of time I won't go into the details of this study, but they found that at the end of 5 years, again HALT glasses, they have a better outcome in terms of myopia control compared to the single vision lenses. So over a prolonged period of time also, they have a good effect. So important conclusions as far as these two types of glasses which are more commonly used is that when there is a difference in the wearing time according to the studies, it has been found that increasing the wearing time of HALT glasses has better myopia control, but when it comes to DIMS glasses, it doesn't happen like that. So even if the child is wearing for 5 to 6 hours, he will have a good myopia control also. Starting optical treatment earlier in age has been found to be better outcome compared to older age group, and it has, according to Mark Bullimore et al., they have suggested that though these studies are in East Asia, you can extrapolate it to other ethnicities also. Obviously, if one therapy is not working, you can go for combined therapy also. The third type of, this DIMS or HALT can be combined with optical treatment or orthokeratology also. The third type of lenses are the KARE lenses, which are called cylindrical annular refractive elements. They are being marketed by Zeiss company. So again, they have a central refractive zone and the paracentral concentric rings, just like our multifocal lenses. And according to one study, the effect has been not as good as with the other type of lenses which has been studied. The fourth, DOT glasses, they have not come into the market so far. They are studied in in Britain. They are called diffusion optic technology. It is slightly different from the other 3 lenses which I just described. They have in the paracentral zone, they have something called diffusers. Now, they are believed to be working on a theory that they in myopia, there are certain photoreceptors which are not optimally working. So they these diffusers, they suppress the abnormal cone stimuli, and increase the contrast signaling, thereby preventing axial elongation. According to their study, they have been found to be very, very effective. So let us see what happens when it comes to India. When you compare these glasses with low dose atropine, I mean definitely, just a minute please. I mean, the ease of use with glasses is much more. If you can't, I mean, if you expect a child to put drops every day for 2 or 3 years, slightly difficult compared to just wearing glasses. The only problem is all these studies are single center trials. So according to Radhakrishnan et al, a multi-center trial have been tried, but not as extensively studied as with diluted atropine. Coming to the cost factor, because India is a cost effective market. So if you compare these two, I mean the diluted atropine versus multiple segment glasses, at the end of 2 or 3 years, the cost of therapy is not different. But yes, definitely low dose atropine is cheaper than the glasses. So with this, I would like to conclude by saying that these glasses or multiple segment glasses are effective, at least in 62% of cases. They don't have any pharmacological side effects on rebound phenomenon once you stop using that treatment. These are my references.